we get through.
Okay.
Any questions for me?
How are you?
Yeah, how are you?
We
We're
need our
sweating over here.
pages next Monday.
Oh.
The chapter 2 workbook.
Oh,
Yes,
my
I believe
Lord.
so, the 17th. So bring your workbooks in with the chapter 2 complete, okay? And then I will go through and look at them, okay? Yeah.
What if our workbook won't be here on time? Like,
I
You
can
don't-
print
you won't
you
get the points for it unless
if
you
anybody
make
needs-
copies of somebody else's workbook to prove, so.
If anybody needs copies, I can print them out, or I can email you a PDF and print them out.
that would be great, because I don't think, like, they were all out on Amazon when I ordered.
I bought mine as in a PDF format for $30.
It says like the 19th to the 22nd.
I'm gonna need it.
So I'll send my email address
Scavenger hunt freaked me out, so I brought like both this textbook and Merrill's and the Merrill's also because I didn't know what the scavenger hunt was. I wanted to come prepared.
I wonder if we're gonna have to carry around all 3 volumes. Surely not. But I don't know.
Let's get started. So we're going to talk about equipment today, and a little bit of this overlaps with some of the stuff we talked about last week as well.
His recorder started playing music.
I was like,
It sure did.
okay, so what's diagnostic yield? Well, it's the amount of clinically useful information on a diagnostic image. So how much information on there is clinically diagnostic, okay, or how much we can use on it, all right? So different types of modalities require different types of information on there, okay? So you've got radiography, sonography, they kind of tell like if cysts are like filled with fluid or if it's more solid filled. Makes a big difference when we're trying to figure out if something's cancerous or not. What else? So another thing like sonography would do over radiography would be, we could tell if that cyst or that tumor has vessels feeding to it, okay? Which is another kind of important thing for like the surgeons to know, because if they go in to take a tumor out, and this tumor has all sorts of vessels going to it, like that's feeding the tumor, well then that's going to cause a lot of bleeding and stuff when it comes, you know, when they try to take it out. So it may or may not be the reason why they can take the tumor out, or maybe they do radiation therapy or something else to try to shrink it before they surgically remove it, okay? So like CT, it's going to give us a lot of views from different projections, okay? Where radiography is just one, right? Just one view. Well, CT is going to do axial, sagittal, coronal, all those different views, okay? And if we don't know what those are yet, don't worry, you will. It can also differentiate between tissues, which radiography does a little bit, but not a whole lot. And it can handle like your low contrast resolutions too. So MRI is really close image-wise to CT, except that MRI is better for like inflammatory processes, muscle, like tears, things like that, where CT doesn't necessarily pick that up. And so CT would be better for bone, okay? So if I'm looking for, maybe a kid had, broke their bone and we can't tell if it's going through their epiphyseal plate or not, okay? And so we might not be able to see that on plain x-ray, but we can do a CT of it because it really shows the bone, but we probably wouldn't be able to see it in MRI. We could see all the inflammation around it, but not necessarily those tiny fracture areas. Does this mean you can't see any fractures on MRI? No, we can still see some, but just not as good as CT. And then there's nuclear medicine, which is kind of a whole nother beast, where that's where you inject, you know, your radioisotopes into your veins, okay? Well, we don't do that in the other areas, okay? So it kind of depends on what the doctor is looking for when they pick the modality of choice, okay? So this is all great, except that, you know, insurance kind of comes into play, and sometimes they have to order an x-ray, like plain films, before they do any of the other specialty stuff, because insurance requires it, okay? So let's see, what else did I want to say? Any extraneous information? So basically, to get the highest image quality and the highest diagnostic efficacy, we've got to make sure that we are taking the best images we can. And you would think like, oh yeah, duh. I mean, I'm trying to take my best pictures, but you'll find that when you get out into clinicals, you'll run across a lot of techs that just don't care, okay? They're just taking the picture to take the picture, and they don't necessarily care or know what a good image looks like, okay? So that's one of the things that we, that's really important for radiology, is knowing what a good image looks like, all right? And you're gonna learn that throughout the program and your procedures classes. That's kind of where all that comes in. So let's talk a little bit about the x-ray machine. So you've got your x-ray tube and x-ray tube support, all right? Collimator, table, generator and control, upright image receptor, and Bucky. All right, so this is best just to show you. So, you've got your two Buckies, okay? So here's your upright Bucky, all right? And table Bucky, okay?
You said table, Bucky?
Table Bucky.
Okay.
Makes sense, right? Table,
Yeah.
Bucky, upright Bucky, okay? Here's your x-ray tube, all right? Your tube support is gonna be up here, you know, this little sheet thingy right there. There's your tube support. Your collimator is here, all right? This is the collimator. That's what's adjusting our, like, field of view on our images, all right? The generator is this machine right here, okay? And you're gonna see all these in every x-ray room. And then your control panel is this back here. So when we looked last week and I was showing you like about techniques and taking the images, that's our control panel, okay? So here's your x-ray tube design. So you've got your cathode and your anode side, okay? So your anode is your positive side and your cathode is your negative side. And the way we can kind of tell is that this machine doesn't have it. I think it's because it's, I don't know why actually. But most of the machines have a positive and a negative on it. It'll have a plus or minus side right here on each side. So then you know which side is the cathode and the anode side, okay? So the radiation acts through the tube window, and the housing is directed towards the patient. So here's your window. You know, this is kind of where the collimation, you know, you're gonna see where it's collimating. There's a light up here, and you're just adjusting these knobs here, making it open and close, and then they're like little, what did I say? This is Sarah's. Here we go. I think it's aluminum in there that you can see moving as you're closing, and that's what's kind of blocking all of the radiation from coming out, okay? So the size of your light or collimation is the amount, is what the radiation is coming out of, okay? That's how much radiation, the area that's coming out, okay? So collimator, again, controls the size and shape of the X-ray field directed towards the patient. Remember, this is important because we want to collimate down to our body part. Because if we don't, and we leave the collimation way open, bigger than our body part, more scatter radiation is coming out, okay, which is bad. Some of them are automatic, okay, and some of them are manual. So what does this mean? Well, when I put a 14 by 17 cassette into my Bucky, the collimator automatically knows that and collimates to the 14 by 17, okay? Or if I have a 10 by 12 cassette that I put in there, or image receptor, it will automatically collimate to that. All right, so how does that transition into the digital world? Well, that would be like the body part I pick, okay? So if I picked a hand, my digital machine will collimate down to like an 8 by 10, okay, or a 10 by 12, whatever the machine is set at.
So, you said the two common SIDs are 72 and 40.
Mhm.
So would it collimate based on the, does it know like the distance from
It
the
does,
image?
it does know, yeah.
So would it collimate for that too?
No, it just collimates to the size of the image receptor. So if you're at 40, still will collimate to the 10 by 12. If you're at 72, still collimates to the 10 by 12. Does that make sense?
Okay.
So, if I'm at 40,
Mm-hmm.
and I have a 14 by 17 in there, it'll collimate to the 14 by 17.
Mm-hmm.
But if I'm doing a chest x-ray and I'm at 72, it'll still collimate to the 14 by 17,
Okay,
okay?
I got you.
Table. So the table can be fixed height or variable height. That just means that some tables, mostly fluoro tables, are fixed. You cannot move them up and down, okay? They're at, you know, this height, and that's as good as it gets, okay? So, lots of times the fixed tables have little, steps that are built into them. You can pull the little step out so your patient can step up on there. It gets a little trickier when you have an older patient and they're trying to get up on a high table. You know, you really have to be there to support. Your variable heights, you know, you can raise these up and down. Okay, that's all that means. Okay. We've got floating tables, 4-way floating tables. So that just means it's gonna move whatever way I want. Back and forth, up and down, okay? The tabletop is radiolucent, okay? So obviously has to be, right? Because we've gotta be able to see through it because the x-rays are coming down through, hitting the image receptor underneath, so it needs to be radiolucent. These are the fluoro tables typically, they have a tilting capability. So this one does not, okay? This is not a fluoro table, all right? So your your fluoro tables will tilt like this, all right? Which makes sense. If anybody's ever had an upper GI or anything, you know, you typically stand on the table. Then you put like a little, footstool on the bottom of it, your patient can stand on it, and then you can tilt the patient back and forth. You can lay them down, you can stand them up, okay? So that's what it looks like, and that's a fluoro table, okay? And these again are the ones that usually don't raise and lower. Some of your newer ones now do, but it could be either way. There's lots of different brands out there and lots of different designs, okay? So there's that little detachable footboard that I was telling you about, okay? Those little suckers are real tricky to get on and off. But you can do it. So just, if you're in your clinical side, you're like, oh, put the board or your foot table on, then you're like struggling with it. No, that's normal, okay? It's not just you being a newbie. Bucky assembly. So this consists of your receptor tray and your grid. So so your tables here, your upright and your Buckies and your table Buckies have their grid usually built in, okay? Some have removable grids that you can take in and out, but this one doesn't. The grid's already in there, all right? If for some, you might ask, well, what happens if you do a body part that doesn't require a grid? Well, so then we have to do it tabletop, okay? So then we put our image receptor on top of the table to do it, okay? So instead of doing like an ankle x-ray with our image receptor in the Bucky, okay, we just put it on top of the table. To take my x-ray, okay? Because I don't want to grid it on an angle, okay? Anybody ever had an x-ray where they're laying down on the table and they feel the table shake? Yeah? No? Okay, so what that is the grid oscillating in the table. And it has to do that because it has grid lines in it. And if it doesn't do that, those grid lines show up in our x-ray. So it shakes a little bit to blur those lines so you can't see them on an x-ray. So that's what that grid oscillates during exposure means. So the Bucky is going to be used for everything. I mean, you've got a Bucky in your DR, CR, and film screen, okay? Always a Bucky somewhere. So this is basically saying that they have stationary grids, all right, and no trays. So like in our digital room, when we were back there and I was showing you and you can't take anything out of it, that's just what that's saying, it's stationary, okay, so it won't come out. But our digital room, actually you can remove the grids from that room, okay, but not this one. So your control panel, it's your interface between the radiographer and the sophisticated electronics of the X-ray machine. Let's see. It has your exposure button on there, which is really important. Right there. That's where we take the pictures. It has your main power switch on it. It has your exposure factors, how we select them. All right. They all look a little bit different, but they all do the same thing. So if you can work one, you can work them all, okay? So your exposure factors was that mass and that KVP that I was adjusting last week in class, or, back there in the lab, okay? It'll show us the visual display of our X-ray exposure, okay, and the display of the exposure factors. So like the audio part, you can hear it beep, okay? That's what that is. We all good? All right, let's see. So most of them are microprocessors, and they use a simple computer interface with them. It lets us change our mass and our KVP and our focal spot size, all right, and our automatic exposure control, which we haven't really talked much about yet, and then our anatomical programming. So when I was going through and picking my body part, that's what it means, anatomical programming. Okay, I'm just picking the body part that I'm getting ready to x-ray. Your automatic exposure control is a little bit, so that kind of makes your life easier as an x-ray tech, but you need to know how to use it, all right? Because what it does is I'm gonna set my KVP on my machine, okay? And then it automatically generates the mass for me, okay? So it basically helps me to take a diagnostic image, okay? So as you could probably tell last week when we were talking, like it might be hard, I got a lot of questions on how do we know what mass and KVP is set? Well, you don't until you get into the field, okay? And then you run into a lot of techs that still don't know how to set their own techniques, okay? Because they rely on this AEC, okay? Which you can set on your control panel back there. And what that means is that, so the AEC uses these cells here, see these 3 cells? And it decides, based on your body part, how much radiation to give that patient, okay? So if I were doing a chest x-ray, like a PA chest x-ray, I'm going through, I'm looking at my lungs, okay? So I have to know which cells to select that. So I'm gonna select these outside cells for my lungs because that's the area that I'm looking for, all right? So when your patient's up here, it's gonna go through those 2 outside cells because I want it to go to my lungs, and then that's gonna decide how much radiation to give that patient, okay? But when I'm doing my lateral, okay, now my lungs are on top of each other like this, right? So they're not like this anymore, they're like this. So I wanna make sure that I'm going through the center of them now, okay? So if I were to pick these outside cells, I would miss my lungs, okay? And then I wouldn't get the right technical factors for my image. Does that make sense at all? Okay, so that's great for big body parts, okay? But the reason why my gripe is that it's not for all body parts, okay? So if I were to use a wrist, you can see how I'm not gonna, it's gonna miss some of my wrist, okay? Because my wrist doesn't cover up all of the cells, okay? Or hands, you know? This is not gonna be a good image, all right? So what it's gonna do is it's either gonna give them too much or not enough, all right? To get a good picture. So it's important to understand, and you will eventually, not yet, how to use this automatic exposure control correctly, all right? So what happens is you'll see a lot of techs using it when they shouldn't be using it, okay? You should be setting your own techniques for some of that stuff.
Do you typically use that for a hand x-ray, or do you use it?
No, you would put it on the table. I was just, but the table doesn't show the cells like that, right? So it's easier to show you on there. But, so that's kind of the idea behind the automatic exposure control. B, positive beam for automatic collimation. Positive beam limitation, yeah. Do you know what electronic masking and shuttering are?
Is that, well, is the shuttering, how long it opens and closes for the radiation to come out? I'm thinking like a camera.
It's, the shuttering is more like after your image is already taken. I think I don't know if I showed every group, but some groups, when I went in and I cropped off part of the image, yeah, and I said, don't do that. Yeah, that's gonna be some of that. Sorry, I gotta. Or coning your image is the same thing. You can cone down after you take the image and the image pops up on your image receptor, but you don't want to cone off body parts, okay? That's illegal. You don't want to do that, okay? If you cone off body parts, what happens is, so if So let's say I am taking a wrist x-ray, okay? And I'm supposed to collimate to about here to here on a wrist x-ray. But I was being lazy, and I opened up the collimation because I didn't collimate close enough like I should have, all right? And sometimes it just happens, like you're like, oh Jesus, like I can collimate a little bit closer on that one. No big deal, you know, like it happens to all of us. But I'm talking about the things that, and that's fine, but you need to send your image the way it is, all right? So if you didn't collimate down close enough or tight enough to your body part, then you shouldn't go back later and fix it, okay? So what happens is, then you get an x-ray that pops up that's like here to here, okay? But I'm like, ooh, that doesn't look good. So techs will go in and then they'll cut like this part off that they didn't need, okay? Well, the problem is, if you take the image, you're legally required to show all that image to the radiologist, okay? So if you cut that off and there's a fracture, or, you know, maybe they even have bone cancer or something like that, and there's a little spot down here, and what you've done is cut it off, all right? And now you sent it to the radiologist. They read it as normal, but later comes back around, because you can tell if somebody's cropped an image, that you've cut that off, okay? Because maybe the, 6 months down the line, the patient's like, oh, well, they got the whole picture on there. And they're like, what? And then they go back and look, and sure enough, you did, but you didn't send it, okay? So that's where the legality falls in, okay? Because you took the image, but you didn't send it, okay? So you're asking, well, what's the difference between that and maybe just ordering a wrist and then you would have missed it anyway? Well, that's true, but that doesn't fall on you, okay? That falls on the ordering physician. Should have ordered a forearm and not a wrist, okay? That's not our problem, okay? But our problem is when we clip off body parts or cone off body parts, okay?
Why would they even make that an option if you're not supposed to do that?
There's good reasons to do it, because sometimes your machine doesn't crop your image correctly and you have to go in there and fix it. So
As long as it's not a part of the body that's being
right, you don't
cropped
want to
off.
put body parts off that you
But like if
x-rayed.
you had like the arm and it was like really wide, like with empty space, like you could take it in as long as it wasn't.
Right, and I don't like that either, because you should have collimated down. But
Well,
that's
yeah,
at least
but-
not illegal, okay? So, another reason, like I said, sometimes the machine, depending on like the body part or the way you position the patient, because not everybody is walkie-talkie and easy to x-ray. Sometimes we don't get the patient centered on the image receptor, and it kind of throws off all the software, and you'll get weird collimating on there, and so then you can go in and fix it. So maybe it accidentally cropped off part of your image, so then you can go and open it up, fix it. So that if they turn it all the way off, you can't do any of it, okay? You just have to be knowledgeable enough not to do it yourself. Okay, so when you get to clinicals, you're gonna see your techs do it over and over and over again, all right? All I can say is just don't be like those techs, okay? You guys do better. And sometimes they'll come and do it to your image, and that's really frustrating for you guys, so, we know, but there's not a whole lot we can do about that. Okay. All right, already done that. So we talked about this last week, all right, how you adjust your KVP and your MA and your seconds and how all that works, okay? So the machines are programmed so it won't allow you to give like an X amount of radiation, whatever that might be on the machine. It's obviously gonna be different if you're at a pediatric hospital than an adult hospital, okay? An adult hospital might be set, it won't go over like 400 mass, okay? The machine will just quit giving x-rays at that point. But at a pediatric hospital, you're not gonna need as much radiation to get a good image on a pediatric patient as you are an adult. So those are set way lower. Not something you do, but it will allow that. Okay. Yes, I will. Yes, I will. Oh, why did it quit? Tube supports. So you've got a couple different types of tubes. We'll just go to this slide. So you've got floor mounted and then ceiling mounted. So this one's ceiling, obviously. See our tubes just situated up on the ceiling, okay? So there's also floor mount ones where it's like hooked to like a big arm, basically, and it's on the floor, okay? So in the hospitals, you're gonna see this, mostly. I've worked on a few in doctor's offices, and they suck real bad, okay, that are floor mounted. Because when it's floor mounted, you can't do your like cross table stuff very easy. So, because if the floor mounted one they're always mounted on the back side of the table, okay? Well, if I need to do an x-ray where I have to shoot across my patient, all right, I can't do that very easy, okay? So what happens on the floor mounted ones is that, you know, you gotta move your patient around different ways instead of just leaving the patient where they are and moving the tube, okay? Because it's stuck on that one side. And I mean, they're fine for just like regular stuff, you know, TVs or whatever, but then somebody always comes in that needs something squirrely and you've gotta shoot through and then you're like, ugh. Then you gotta move your patient all around. So, tube crane. So what I just did when I moved the tube all the way around, that's what that is. Uh-oh. That's what's going on there, all right? There's a lever on this one in the back that does that, okay? Some of your digital machine, the lever is on the tube, okay? That moves it. You can angle. And this one is up here. Okay, you can angle your tube. required for some of your x-rays. You two can move back and forth. Back and forth. You've got, you can, on some of these, you can, a lot of the newer machines, you can adjust your mass and your kVp out here. You don't have to go back there, okay? So maybe I'm working with another tech and they set my technique back there, but then I realize like, oh, I don't like what they set. I can do it out here for myself if I want to, no big deal. Or maybe, you know, they set a technique, but when I come out here, I realize that that the patient's not normal somehow. Like there's a pathology of some sort that's gonna need to be adjusted where they can't see it because they're not doing it. You always have to, when you're in rooms, like x-ray rooms, you always have to go behind the control panel to take your x-ray, okay? There is no switch out here that allows you to stand out in the room and take your own picture, all right? It's a safety mechanism. Now, on mobile machines, you can, but not like in-room machines, okay? There's your vertical or upright Bucky. They have arm supports on them. I don't have one on that machine, but they usually you can take them on and off. Okay. So your image receptor, that's going to receive your remnant radiation. So that's the radiation that passed through the patient and struck the image receptor. Okay. Cassette based and cassette less. Okay, so basically that just means there is a cassette or there's not a cassette. Okay, so like our digital room, where we were at last week, that's cassette less because there is no cassette. Okay. There's your image receptors again. We talked about those last week. So, important to remember, the only radiation that is of any clinical value is going to be your remnant radiation, all right? So that's the radiation that strikes the image detector. Well, there's a barium enema. That's what that image
Oh,
is
I was
of.
like, what is happening?
Yeah, so that's when they have a tube that goes up their rectum, and then we put barium in that and fill up their colon.
So why isn't the whole thing white?
Because there's air. You don't want to put in so much that it fills
Okay.
the entire thing. 'Cause
Okay.
they wouldn't be able to hold it. So. So we're not going to go through all this again. Oh, there's your, where it replaces. So 8 hours on a plate loses as much as 25% of its original value. After the plate has sat there, or image receptor, or cassette, all the same thing, after 24 hours, you shouldn't use it, okay? So every once in a while, what happens is somebody goes to do an x-ray, then they get pulled away from something, and then they set the cassette down somewhere, and they forget about it. And then that's why it may sit that long. But it shouldn't ever just be randomly sitting anywhere, but, you know, things happen. Maybe their trauma came in and they had to go, you know, and then got caught up in that and forgot about it. And the nice thing now, at least, is that, well, you scan your patient's name in on them, where back in the day, you didn't do that. You took the x-ray, but there was nothing really associated with that until after you ran the x-ray. And so with the name, you can now at least like run the image, and there's probably a name that's gonna pop up on it because the person's probably already scanned it. But, I mean, not always, but so that you didn't get patients mixed up, but
That's on the image receptor, you said?
yeah, on a one that has cassette, but, so the nice thing with the digital is that you're less likely to get, you know, images mixed up with other patients and stuff that way. So there's a digital cassette, all right, and they're just charging the battery for it, that's what that is. And your digital is supposed to lower patient dose, if you're doing it correctly. Fluoroscopy, again, fluoroscopy is gonna be your live, imaging, okay? So that's just seeing your, like physiology live. There's your little fluoro machine again. So a lot of fluoro machines have your x-ray tube separate from the fluoroscopy unit, all right? So remember when I said the fluoro comes up from the bottom, or the radiation comes up from the bottom, and it strikes the image receptor here on top. There is a bucky here, but that bucky is used for the x-ray tube whenever you want to take a regular x-ray, okay? So don't get confused that way. So they have these drapes here on the fluoroscopy machines, and that's just to help reduce the radiation to the people that are running the machine, okay? One thing that I didn't tell you too is this control panel here is lead lined, all right? This is lead lined, the window's lead lined, rooms in radiology departments are all lead lined, okay? And that's just to make sure that radiation doesn't escape the room. Okay, this makes it safer for everybody. And so that's what this like little lead shield here is for too, just kind of helps, because the lead absorbs the radiation. All right, there's just moving her around, tilting. If you guys have any questions about it, just holler. There's other fluoroscopic systems. It's all considered fluoroscopy. So like you have a C-arm, which is, remember when I took you guys on the tour and there was that little machine in that one room back there that looked like a C and it lit for surgery? Okay, that's fluoroscopy unit as well. It's just called a C-arm. And then they have machines that they use in interventional as well that's similar to a C-arm, but it's just mounted usually on the ceiling. Oh, they all do the same thing. Oh, there's our mobile x-ray machine. I see one like that. So we use these to go take x-rays in patient rooms, okay? So if the patient isn't well enough to come down, then we go to their room. So maybe if they had COVID or something and we don't want them traipsing around the hospital, we'll go up there and x-ray them, or TB or whatever. We use these in traumas, okay, a lot. We'll take the machine over to the trauma rooms and x-ray them in the trauma rooms. So they're a little bit more compact. They don't have as much power as like a regular room x-ray machine does. So if you have like a really large patient, you're not going to be able to get as good an image as you can in a regular x-ray room, okay? So we fight with the nurses a lot on the floors because they may or may not just want to bring the patient down. Well, that's not a good excuse to for us to go do a mobile x-ray on the patient. All right, they need to not be able to come down for a reason, not just because nobody's available to bring them down. And sometimes when you look at the patient and then if they're, you know, grossly obese, you just can't get the x-ray. Like I'm like, I can't get a KUB on that patient with a fluoro or with a mobile x-ray machine. Like they have to come down. So, and sometimes they have to come down whether or not they're intubated or not. Like, you want the x-ray. And depending on what they're looking at. So we've got the newer ones, you know, that are wireless, portable DR detectors. That's what our little fancy one back there is. And then you have some that have a cord attached to them that make them digital, okay? So sometimes they've converted rooms like this into digital rooms by tethering a cord to the image receptor. You gotta always keep them charged, all right? Nobody's gonna nobody ticked me off more than going to do my my morning portables and somebody didn't plug in at my portable machine and it dies halfway through. Whew, that's cussing. Especially when I'm up there doing 20 x-rays. You know, it's not unlikely for you to like just bounce from bed to bed to bed to bed. And then sometimes it'll die and won't move at all on you. So then you gotta leave it where it's at and go plug it in, and then you look like a real great tech with leaving the portable in the middle of the road. That's the worst. There is your C-arm, okay? So this would be what you would take to surgery. There's tomograms that you can do as well. So we would do a tomogram if I needed to do a spine x-ray, all right, I cannot get the spine all on one image, okay, on a regular image. But I can set it up with machines that are compatible to get the spine all on one image, and that's a tomogram, okay? So what it does is I can set the machine up to take a picture here, here, and here, and then there's a software involved, and then it will stitch the spine together, and you'll have a full spine. So that's what it's doing. It's like, let me take a picture here, here, and here, and then when the image pops up, then you have a full picture of the spine. So they'll do that lots of times for spines and like femurs, because we can't usually get a femur all on one image, and if they want to see the whole thing together, that's what we would do. And so to do that, you just hold down your exposure button, okay, until it gets through. So like when I was taking images back there, I just pressed it until I heard the beep and then let up. Well, I would hold it down and it would go beep, beep, beep. So 3 pictures and then let up, okay? So dual energy subtraction. So basically for this one, images are taken back to back, 2 quick exposures, so one's high and one's low, and then the computer processes the image for you. And so afterwards, you can select to subtract certain anatomy out of it. So maybe I was taking an image of, let me think here. So we'll just use a brain. So this typically, you use this more when you're doing like CT and MRI, and maybe I'm doing an angio brain where I'm just looking at the arteries, all right? So I can subtract out all the bone away from all the arteries, and the only thing that's gonna show is just arteries on there, okay? It's pretty cool. So we got various designs in our equipment, but they all like have all those common features that I just told you about. Some are really fancy and do a whole lot of other things, and some aren't. But like I said, if you can work one x-ray machine, you can work them all, okay? Because they're all about the same. All right. You guys are kind of quiet today. You tired? Yeah?